حضرتك يا دكتور.
بسم الله الرحمن الرحيم. Welcome everyone in this new meeting of Egyptian Society of Nephrology and Transplantation, CME meeting, online meetings in our usual date and time, Wednesday, 9 p.m. Today we are honored to have a very special speaker, Professor Mohamed Hani Hafez, who is the past president of Egyptian Society of Nephrology and Transplantation, a past Misal General Secretary, and now he is the president-elect of a friend. Professor Hani is known by his very active scientific activities and very well spread scientific activities all over the Arabic world, all over Africa, and all over the world, in both Arab Society of Nephrology, AFRAN, African Association of Nephrology, and the International Society of Nephrology, as well as our Egyptian Society of Nephrology and Transplantation. And today, because of this very special activities, we are pleasure to have him to give us a highlight for the last nephrology congresses in the last 2 years, dating since the COVID lockdown, and since we started activities again, physical activities again, including World Congress of Nephrology, SN, and lastly, the European Society of Nephrology. Professor Hani will highlight for us the most important topics highlighted in these conferences and make us as if we were there at time. Thank you, Professor Hani, for your talk and your activity with us today. And please, the floor is yours. And we are waiting for a very special topic and your very special lecture today. And because before we start, I would like to welcome all our attendees and all our attending.
Thank you very much, Professor Yasser. It is always my great honor and privilege to be with my professors and brothers and sisters. And I will try in maybe in the next, I hope, 1 hour to give you a good idea of what happened in the World Congress of Nephrology, which was in Malaysia in February 2020, in the last American Society of Nephrology, which was in last November, and a few hits from the Paris European Society, European EDITA, which was last week, just finished a few days ago. Of course, due to the shortage of time, I will not cover everything. I just selected some aspects that would be of interest to most of clinical nephrologists. My agenda actually will go into 8 parts. The first part will be addressed to aging, tertiary lymphoid tissue, and the process of kidney fibrosis. And the second part will be the artificial kidney dream and the kidney engineering advances and how to overcome the organ shortage. These 2 aspects more or less deal in a way with transplantation. Then I will proceed to more important aspect of glomerular disease management. I will address the IgE nephropathy, the membranous, the systemic lupus, the ANCA, vasculitis, and the pediatric nephrotic syndrome, and some hints about sickle cell disease. Then I will proceed to acute kidney injury, which is the favorite aspect for Professor Yasser. And I will take you in a word trip in different AKI in different parts of the world and see what is the real status of AKI in different countries. Again, we will go for the privilege of Dr. Hisham Said, the innovation in dialysis, giving you about an idea about the roadmap for innovation, starting with the membrane, new membranes, then the artificial intelligence and how it can control the dialysis in the future, and the American program of spreading the dialysis and the transplantation by 2030 to every part in the United States. Then I will go to speak about green nephrology, which is an aspect that has been raised in the last Glasgow conference that has been attended by more than 50 presidents and kings of different countries in Glasgow, addressing the warming problem and the CO2 emission in the world, and how can we get a world with less CO2 emission and what we call green nephrology. Then I will proceed to malnutrition. Does it have any relation to nephrology? And lastly, I will finish with a vascular calcification aspect, which is, I think, an important topic for Professor Tariq Elbaz that I hope will be with us. So let's embark into our agenda, starting with aging and how aging can affect the kidney. When you look to the aging and you see that there is fewer nephron due to injury, there is decline in the renal function and the hypertrophy of the remaining nephron, with accumulation of senescent cells or old cells, with some nephrosclerosis of the vessels, with more interstitial fibrosis, and with dysfunction of the tubular epithelium. You think that ultimately all people, like what Professor Megiddo has mentioned one day, ultimately will have some element of renal dysfunction. But actually, the story is not that bad, because, okay, on the molecular level, we have these aspects, but still the function is maintained. And according to this Japanese study that has been presented in the World Congress of Nephrology, they are trying to explain what happens in the aged kidneys. They found that there is accumulation of tertiary lymphoid tissue. And this lymphoid tissue will be composed, as you know, of B cells and T cells. And you see here, they found a type of senescent associated T cells that we call SAT cells that you see here in purple. And this SAT cells is carrying one molecule here is called CD153. And again, they found a senescent or an old B cells that are calling ABC or age-associated B cells that increases with age and also is carrying some marker for it. And they concluded that they identified these senescent associated T cell and these age-associated B cells promote the formation of tertiary lymphoid tissue, and that they activate each other through CD153 and CD30 signaling to expand what we call the tertiary lymphoid tissue. And this tertiary lymphoid tissue, which sometimes we find even in transplanted kidney, has been documented in transplanted kidney, and it could be one of the causes of fibrosis, progressive functional decline, and progressive fibrosis that is taking place with aging. So they are trying to see why renal fibrosis is taking place and why there is dysfunction, and they are attributing this to this T lymphocyte and B lymphocyte associated with age, ending in what we call the tertiary lymphoid tissue. This is the first aspect. The second interesting aspect is what we call aging, and a new aspect called FUDUM, as has been mentioned in Nature Review in this publication, giving stress on food as medicine. So what do we mean by FUDUM? FUDUM is a new name or a new discipline that studies the food and nutrition domains through the application and integration of advanced omics technology to improve well-being, health, and knowledge. In short, FUDUM means that we use our food as instead of drugs to get better health. So the complex FUDUM include 25,000 substances that make up the human diet. And they tried to analyze these substances present in the human diet to see what is beneficial to the human and what is injurious to the human. And according to this aging theory, they found that some unfriendly gut bacteria are linked to early aging. So whenever you have these bacteria in excess, you may have increased possibility of early aging. Because these bacteria, that is gut microbiota, will lead to atherosclerosis, thrombosis, cardiorenal fibrosis, modulation of inflammation, immunity, and vascular function, modulation of lipid metabolism, renal dysfunction, and blood pressure, myocardial repair, and module inflammation. And these microbial metabolites, some of them are trimethylene, for example, N-oxide, or phenylacetylglutamine, could be injurious and could be combated by other types of microbiome. Therefore, what are the anti-aging diets? According to this, if we can get more healthy diet, in one word, it is actually the Mediterranean diet that is present with more vegetable, more vegetarian diet, we could overcome this process of early aging. And I will give you one simple example of one vegetable and one fruit. This vegetable, for example, is the broccoli. And I found that in this broccoli, there is sulforaphane element, which is present in broccoli. It reduces the hepatic glucose production and improves the glucose control in patients with type 2 diabetes. This means that if you eat broccoli, this exactly is as if you take a tablet of metformin. This is a vegetable. An example of a fruit, I am trying to give you some appetizer before entering into the more deep subjects. If I give you some strawberry, and the strawberry here is containing a chemical called phyzetine, which is a xenotherapeutic that extends health and lifespan. And this phyzetine may be a low-hanging fruit for aging, and its content of phyzetine in the strawberry is 160 compared, for example, to the apple or the onion, which is only 26 or 5. So eating strawberry and eating broccoli will be an example of how you may delay the aging process. And this theory actually is based on these types of Mediterranean food. Here we see, for example, the olive oil, we see the cheese, we see the vegetables. This will work on the gut microbiota, modulating them and increasing the intestinal barrier integrity. Also, it worked on the NF-kappa beta, decreasing some elements like rankle and the tumor necrosis factor and interleukin-1 beta, and increasing other elements like IKK. In the same time, the NRF2 and the reactive oxygen species are decreased. The combination of this Mediterranean diet, which is healthy, leads to the following: benefits on cardiovascular disease, diabetes, and also chronic kidney disease through the immunomodulatory effect, decreasing the inflammation, decreasing the oxidative stress, and increasing the inflammatory factor, which is leading to age. So in this food as a treatment, this is the first part of my talk. The second part of my talk, I will give you a very rapid hint of some advances in the field of transplantation. And then I will elaborate maybe next month with Professor Ayman Rifai about more advances in transplantation, because there is no room in this talk now, but I will just give you a few hints. There is new advances in the kidney engineering from pluripotent stem cells that has been presented by Professor Melissa from Australia, that they are trying to get kidney organoids and kidney progenitors. And there were, in Paris, there were much talks about these kidney organoids. to try to get the kidney in a petri dish, because this will be a good medium to study different drugs on the kidney, and maybe cellular therapy in the future, and development of our dream of artificial kidney. This dream has been forwarded by Professor Rimuzzi in the future, in the past, when Professor Rimuzzi all the time was trying to making a functional renal organoid after implementation in the host. And his problem was the vascularization, which is enhanced by this growth factor. But he did not succeed actually. And therefore, there have been some advances nowadays, convergence between a different procedure to improve the vascularization of these grafts. And this is an example of what has been presented, requiring a complex microtissue containing nephron, proximal tubule, distal tubule, and even some nephron progenerators in this important paper in JASN 2019, trying to get better vascularization than the early trials of Professor Rimuzzi. And this could give you an idea that in the future, maybe not in the very near future, but in the future, we will have a possibility of getting more nephrons. Now, as you know, they are trying to increase the number of nephrons. This is an example of the mouse nephron, 16,000 nephron, and the human nephrons, which is reaching 2 million nephron, average 1 million per kidney, as you know. And they are trying to develop the vasculature, which was the remaining part in this bioprinted organoid regeneration. This is Professor Antonio Atalla, which tried to do the 3D printed kidney. But again, this 3D printed first trial was obstructed because of lack of vasculature. And these are new publication in 2021 telling that they are trying to overcome this difficulty by some new experiment that will make this possible in the future. A real advance that took in the field of transplantation that all of you heard about is the pig to human kidney transplantation. And this has been done by Professor Montgomery. Professor Montgomery himself is a cardiac transplant patient. And he got some ethical framework before doing his experiment on 2 patients. He used a brain dead recipient, and the family agreed to pursue the experimental xenograft transplantation and transferred to a designed ICU and he got an FDA approval and Department of Health zoonotic disease surveillance to avoid the transfer of pig diseases into human. And then he did one of his surgeries in last September 2021, and the second surgery was in last November 2021. Each of these kidneys, as you see, was left partially exposed in the recipient. It was not totally closed, so that they can take biopsy and see what is happening from time to time. And here, the implantation xenograft anastomosed with the femoral artery and vein and left outside the body for ease of direct observation for signs of hyperacute rejection and for performance of serial biopsy. Fortunately, up to many hours, as you see here, up to around 50 hours, nothing happened. It worked well. Immunosuppression was 1 gram of methylprednisolone daily and 1 gram of intravenous mycophenolate twice daily until they remove the kidney after 54 hours. So I think this is a very encouraging preliminary result about the future, that we can overcome the organ shortage either by bioprinting like Antonio Atalla tried, or by xenotransplantation like Montgomery tried. I stop here in the transplantation issue, and I will embark with you into clinical nephrology, starting by glomerulonephritis. And the first part of glomerulonephritis that I will speak about is 5 new drugs that could be used in the treatment of IgA nephropathy, according to these 5 publications. The first of them is the budesonide. Of course, you know that budesonide is a derivative of steroid that is used as a Pulmicort in the treatment of bronchitis, asthmatic bronchitis, and also it is used in ulcerative colitis and Crohn's disease. Here, they completed recruitment of more than 300 patients, and the inclusion was more than 18 years, biopsy-confirmed IgA nephropathy with a proteinuria of more than 1 gram, and GFR between 35 and 90. And the primary endpoint was in the first 190 patient, proteinuria reduction in 9 months, and they followed them. They found the following. There is a mean reduction of the proteinuria of 27% compared to 5% in the control studies. The GFR was higher by 7%. So it is a promising result, and this is coming from a Canadian study. The second drug here is the PROTECT study using not only the ARB. You know that the irbesartan is helpful in IgA nephropathy as other ARB, but they compared here the combination of ARB plus an endothelin blocker. And this combination of endothelin blocker and irbesartan together is called sparsentan. And as you see here, very astonishing results. When they give this sparsentan, there is a 50% reduction in the baseline proteinuria compared to only 15% when they used irbesartan alone. And in the next slide, you see here the DUET study, which started the use of this angiotensin receptor blocker with the endothelin blocker on the podocyte and how they act. And this was the first study. It was in focal sclerosis patient. It was very promising. And this drug, by the way, is used since long time by rheumatologists under the name of Retrophin. So it is present in the market, and now it is time for the nephrologist to use this drug in different indication. One of them will be, as I told you, in this PROTECT study, IgA nephropathy. The third drug that could be used in IgA nephropathy, all of you are aware of, are the SGL2 blocker. And here we see the dapagliflozin, and which now is used not only to control diabetes, but also to control some renal disease. And you see here in this comparison, in the primary endpoint, those patients who got the placebo did not got an improvement in the proteinuria and GFR as compared to those who got in blue, the dapagliflozin. So now we have 3 drugs, budesonide, we have the sparsentan, and we have the third drug, SGL2, like the dapagliflozin. The fourth drug here was an important study coming about a very cheap drug, hydroxychloroquine. Hydroxychloroquine, you see here, the arm which took the hydroxychloroquine in gray here, after 6 months treatment, there is a 50% improvement, a reduction in proteinuria compared to only 14.8% in those who did not took the hydroxychloroquine. And the target here in this phase 2 study is the toll-like receptor number 9. Again, there is a 5th drug promising, which is called iptacopan. And this iptacopan is actually acting on the complement pathway, on the alternate pathway of complement factor B. And they found very promising result that assumes that IgA nephropathy has got an element of complement associated pathogenesis. And therefore, nowadays, in conclusion, we have a target release formulation of budesonide. We have SGL2 inhibitor. We have promising data in this sparsentan. We have iptacopan, and we have the hydroxychloroquine, and still ongoing trial about other drugs that are got some investigation number, and I will not bother you by names of things which did not occur yet. But at least now we have 5 drugs that you can start using them. 2 of them are very cheap and available, like hydroxychloroquine and the SGL2 inhibitor, and of course the budesonide, the corticosteroid. Now let's move to membranous nephropathy. As you know, many cases of membranous nephropathy need no treatment. So this important study, which was presented last week in Paris, is putting a number of patients, 127 biopsy-proven membranous patients, followed for 6 months. None of them was taking immunosuppression, no immunosuppression, or received the standard of care, diuretic, statins, and RAS inhibitor. And they only measured the titer of the PLA titer and see is this titer, anti-platelet is beneficial to predict those patients who will get proteinuria or not. And the primary endpoint was 50% reduction in the spontaneous remission of proteinuria. And remember these 2 numbers. If your titer is less than 40, your patient has probably spontaneous remission. And if your titer is more than 275, probably your patient will have no remission. So I think in our practice, we can start asking for this anti-PLA titer before starting immunosuppression. If you find it more than 275, start immunosuppression because your patient will not get spontaneous immunosuppression. But if you find low titer, there is no need to give immunosuppression. The patient will improve by himself. So this was very important clinical study that is very helpful for all nephrologists. The third part of GN that I will speak about today is the lupus nephritis. And of course, you know that the schematic diagram showing the immunopathogenetic pathway leading to kidney damage in lupus nephritis is multifactorial with emerging novel therapy targeting specific pathways. Some of them that I will mention in detail after some time are dealing with the T cell, some of them addressing the B cell, and the interaction here by CD20, for example, rituximab and obinutuzumab. Some of them will address the plasma cell. Some of them will address the kidney fibrosis. And let's go and see what are the advances. And again, I will give you 4 new drugs for lupus. The first option was presented by this Hong Kong study by Professor Daniel Chan from Hong Kong. That is, he made an important presentation about triple immunosuppression. Simply remember what we are doing in transplantation. He did a Prograf, MMF, and steroid protocol and followed his patient for 3 years, 36 months. And he found after 1 year, there is almost 60% response. And after 3 years, almost 77% response if you use simply the triple immunosuppression. So this is very promising. But another option is to use, according to this nobility study, the modification of rituximab, which is obinutuzumab, or the second generation of anti-CD20. And you see in this phase 2 study, which is called nobility study, those patients who took the obinutuzumab that you know here under the name of Gazyva got an improvement in the proteinuria and in the GFR. The third drug is the belimumab, and the fourth drug is voclosporin. So now we have 4 possibilities up till now, and I will give you soon the 5th possibility. In the American Society of Nephrology, there were so many papers about this voclosporin, which is actually, from its name, you will know that it is a CNI because it is very near to the cyclosporin. It's a CNI with rapid reduction in proteinuria during treatment is most likely due to a direct effect of the CNI on the damaged podocytes. And they followed the patient for 1 year, and they found very good response after 1 year in comparison to the placebo. The second drug is belimumab, which is actually rapid reduction in proteinuria, maybe protection for the tubular interstitium with preservation of podocyte integrity, may translate over to better long-term maintenance of kidney function. And these two drugs have been, therefore, included in the new guidelines for the KDIGO, telling that Chapter 10 of lupus nephritis, KDIGO 2021, is telling that you could use these drugs in case the patient does not respond to the classic protocol, and they included them according to their trial of after initial therapy does not give good result. But there is another drug that a fifth drug actually that has got in last August 2021 by the FDA an approval after two phase 3 study called the TULIP and phase 2 trial called the MUSE. After these two studies, they approved this new drug, which is anifrolumab as produced by AstraZeneca company as a type 1 interferon receptor antagonist. It is given by intravenous use 300 milligram vial for treating of moderate to severe lupus in adult receiving the standard therapy, and this, with minimal side effects of infusion reaction, herpes zoster, and some bronchitis. But with these 5 arms for lupus, you are only treating 50% of your lupus patient who have complete or partial remission. So we still need more investigation, and therefore there is more to come. And according to the American Society of Nephrology in the Kidney Week, let's wait for the next year for this newcomer, which target the interleukin-17, like suquilumab, which target the MASP2, like narsoplimab, and other drugs which will come in the future. So the trip did not finish, but at least now in lupus, we have 5 options: triple immunosuppression like transplantation, voclosporin, belimumab, and Gazyva, and lastly, this anifrolumab, which is the new addition in the treatment. Now let's go to United Kingdom. United Kingdom has got a long story in the treatment of ANCA vasculitis. Therefore, Professor David Jane was the speaker in the World Congress about what's new and hot in the ANCA vasculitis. He gave a classification. He gave some pathogenetic elements regarding the genomics and the role of complement, and recent data about the treatment with complement inhibition, and recent data on immune suppressive and steroids remission maintenance with rituximab. And these were his aspect of interest. And you see, of course, that the ANCA vasculitis is, the incidence actually is 20 per million, and the prevalence is more than 300 per million. And it is a wide degree of interaction between different, as you see, 70% in this GPA and 90% renal affection in the MPO ANCA. ANCA here is associated with deterioration of kidney function, and therefore there have been different ways of classification to predict the end-stage renal disease. One of them is the burden classification, and another type of classification is the Mayo Clinic Renal Pathology Society chronicity score, and a third way is the ANCA renal risk score. So we have 3 ways each of these score gives some points to tell if this ANCA is severe or not severe. For example, when we stop at the ANCA renal risk score, we see that the percentage of normal glomeruli, the tubular atrophy and the interstitial fibrosis, the renal function at the time of diagnosis, each of them is taking some point. And according to this, they are putting a risk to see if this high risk or medium risk or low risk. So we have at least in the world 3 international classification. The genetics here has got an important association with 2 PR3 ANCA is associated with HLA-DP, PRTN3, and MPO ANCA also is associated with other genetics. Why is remission important? Why it is important to achieve remission, the earlier the better? Because they found that the mortality in ANCA patient, if you make an early remission, the patient will not die. If you make a late remission, the mortality is high. So it is very important to control in the first 3 months, not after 6 months. So therefore, they want to give aggressive treatment in ANCA at the start, and therefore the standard treatment to reach this remission induction in the period 3 to 6 months is to start by steroids. And if you don't reach by steroid this target, you may add cyclophosphamide or rituximab. And here it is important to compare some studies, 2 recent studies. One of them is called the LOVAS study and the PEXIVAS study. The LOVAS study is a trial of 2 steroid regimen with rituximab induction, and remission rates were similar with rituximab steroid sparing. The PEXIVAS study in severe ANCA-associated vasculitis was associated to ask if does plasma exchange reduce the death from any cause or end-stage renal disease, and same response with much less side effect with rapid reduction of doses of steroid when you may combine plasmapheresis to the treatment protocol. It is very important to know that cyclophosphamide works faster than rituximab. So our old friend, the cyclophosphamide, could be initiated and you can combine it after that with rituximab. But start with with cyclophosphamide, which works faster in these cases if it is aggressive. And here you see rituximab better than AZA for maintenance. After that, for maintenance, rituximab will be better than azathioprine. And in the mycophenolate mofetil trial, you see the proportion in remission at 6 months was less. So rituximab is a good drug in the maintenance. Rituximab and secondary immunodeficiency. This is a problem with the patient taking rituximab. They found, especially in the era of COVID, that rituximab is responsible for secondary immunodeficiency and is even responsible that humoral and cellular response to the vaccines against COVID was not optimum in those patients taking rituximab. So beware of, happily the COVID nowadays is decreasing. And here the plasma exchange for end-stage will reduce the risk according to the PEXIVAS study that I told you about. It may reduce the risk of end-stage renal disease. Here, it is important to see that the complement still have a role in the ANCA, because in the old classification, when we were speaking about crescent-associated glomerulonephritis, we are mentioning that maybe the complement is not important. But in this new publication, they found that B cells at the site of the GPA inflammation are associated with the presence of complement. And you see in the kidney biopsy, ANCA and complement are important. And you see here the position of some complement in the biopsy. And although these diseases were regarded as post-immune, meaning few immune complex, but nowadays complement is taking an important role to the extent that there is an advocate trial nowadays giving a treatment based on complement. And this treatment, I think you see here, is called avacopan. Avacopan is the treatment, And they found that those patients taking avacopan, you see here, the number of patients is 125, are getting a better long-term response in this publication in the New England Journal of Medicine in comparison to those who are taking prednisone, 128 patients. And the GFR recovery was more notable in those with avacopan. So it seems that the anti-complement are taking an important role in the management of nephrology, whether in IgA nephropathy, as I told you, or in the ANCA vasculitis nowadays. Now, I will go to the last part of the GN, not forgetting our pediatric groups. And here is a 5-year-old presenting with nephrotic syndrome, presented by Professor Mignon McLouche from South Africa. And the summary of the treatment in resistant cases is as follows. Rituximab is now proven effective in those patients who are resistant or steroid dependent. It is non-inferior or better than other treatment. Ofatumumab is possible newer treatment for highly drug-resistant nephrotic syndrome. LDL apheresis is designed for lipid reduction in hypercholesteremic patients. And the sparsentan, which is, as I told you, an endothelin receptor blocker plus ARB that we spoke at in the IgA nephropathy, again, could be used very, very well in those patients with possibly focal sclerosis who are steroid dependent and who may benefit from sparsentan treatment. The last part in the GN, I will address sickle cell disease, which is common in Caribbean, in Tunisia, in some part of Saudi Arabia, Bahrain, etc. It's the renal disease is common and associated with increased morbidity and mortality in persons living with sickle disease. It is not rare as we are thinking. Here we are in this presentation from Jamaica that addressed some issue. Hydroxyurea use independently is associated with a lower likelihood of albuminuria in adults with sickle cell disease. ACE and RB reduce the albuminuria in sickle cell disease, and there is a possible role again of SGL2 inhibitor. So up till now, SGL2 inhibitor is taking place in different parts. Now let's go to the acute kidney injury, and which is the fourth part in my presentation. And I will tell you some aspect about acute kidney injury session here to understand that the epidemiology of acute kidney injury in adults and children varies across the globe. You should see that this the United Kingdom presentation showing the data of high-income country in comparison to low and middle-income country regarding the acute kidney injury. The disease pattern here in high is associated with multiple organ failure, multi-organ failure. However, in low income, it's often caused by a single disease that progressed to acute kidney injury. The mortality, unfortunately, is similar. High mortality in high income, and again, high mortality in low income. So the income does not differ in mortality. Let's look to this figure coming from the JSON, telling that the 30-day mortality here is almost the same. The AKI incidence and the hospital length of stay may be a little bit different between different income country. The main exposure factor in high income country are sepsis, septic shock, trauma, complex surgery, nephrotoxic drugs, and burns. While in low income country, you will find infection, obstetric complication, animal venoms like snake bites, etc., traditional medicine, and we'll go to this in detail in the next minutes. Let's see what's happening in Mexico. In Mexico, this presentation by Professor Guillermo Garcia, who was at the time the president of the International Federation. There is a paucity of information of AKI in this region, but you will see that there is multiple publication addressing there is a 4-fold higher mortality of AKI in comparison to the community-acquired acute kidney injury. The hospital-acquired is 4-fold in mortality higher. And AKI is common complication in hospitalized COVID-19 patients. And also further study are needed to determine the epidemiology and outcome of AKI in the region. Here I will stop and tell you some very bad data about the statistics in the world. It has been presented in the plenary lecture of opening of this Paris Congress that few months ago, they told that the total mortality of COVID in the world was 5 million. And unfortunately, few months later, another publication is coming and telling that the total mortality is not 5 million, it is actually approaching 13 to 15 million. How comes that there is a threefold increase while the calculator every day is telling you how many patients in the world are dying, and suddenly we find that the real mortality is tripled. So this gives you an idea about how the statistics is going, not only in underdeveloped country, but also in developing country. What about the situation in Africa? And here, presentation from Ghana by Professor Adu. There is a striking feature of pregnancy-associated acute kidney injury with high incidence of HELP syndrome ranging from 30 to 40%. And there is actually a problem in Africa that if you get an acute kidney injury, mortality increases to around 75% and 86% in adults because you don't get a facility for dialysis. What about the condition in the Middle East? And this was the presentation that I got the privilege to present in the International Society of Nephrology, telling that we should add different infections, like, for example, hepatitis, HIV, and malaria in our area. You should consider rhabdomyolysis complication in our area with all the hot weather, with all the disseminated intravascular coagulation, with the trauma-related acute kidney injury, because the our trachea is associated with wars. And you see, the first report came from Britain during the Second World War, and the mortality rate at that time was 91%. But in recent war conflict, the incidence of acute kidney injury is still high, but the reported mortality decreased to 13 to 22%. And of course, in the developing world around us, Libya, Yemen, and Russia and Ukraine, there are various causes for trauma-related acute kidney injury, including hemorrhagic shock, rhabdomyolysis, use of nephrotoxic drugs, infectious complication, etc. What about the use of traditional drugs? According to the WHO in 2003, 80% of the world population rely upon traditional medicine for their primary health care. And this is a study coming from Durban, South Africa, telling that among the acute kidney injury presented to the hospital, 20% of the patients were due to nephrotoxin and 30% due to infection. One of the famous causes of these were Chinese herb nephropathy, reported in the literature to be taken by Belgian ladies to try to decrease weight. And they reported more than 300 cases in 2018 from this Chinese herb nephropathy. Again, heavy metal nephropathy is common in our area, mycotoxin, ochratoxin, and we have some publication from Mansoura University. We have this Mesoamerican nephropathy that occur along the Pacific coast and affects men working in sugarcane fields, but can occur with other occupation. And it could be due to an association of heat stress, non-steroidal intake, and pesticides. It is not uncommon, and it is getting a different name in different parts of the world. So this is an example of the biopsy in those patients. And you see here, some lysosomes, proximal tubular damage with lysosome associated, looking very near like those of calcineurin inhibitor toxicity. And this is an example of proposed causes: pesticides, chemicals, heavy metals, hantavirus, leptospirosis. It has got different names like Balkan nephropathy, Chinese herb nephropathy, and a common risk factor is heat stress and dehydration. And there is some countries with reported high incidence. Some of them is Mexico and Central America, India and Sri Lanka, and some places in Egypt like Elminia Governorate. And you will suspect these types of nephropathy whenever you have a patient, young age, coming with unexplained kidney failure and with history of working in agriculture and exposure to pesticides. The fifth part of my presentation will address the advances in the field of dialysis, and I will start by the membrane advances, and this important session was shared by our dear colleague, Professor Mona Rohemi, who presented Professor Laurent Giard from Lyon, who is talking about the medium cutoff and the medium retention onset and the different new membranes. And among these new membranes, he spoke about the matrix-associated membrane, about the bioartificial kidney in which proximal tubular cells are added to the membrane, about the graphene oxide membrane with large pore and reduced thickness, and about the sorbents used in wearable artificial kidney, which is the project of Professor Fiesel, who visited us in Egypt 2 years ago and gave his first impression about the new wearable artificial kidney. So in conclusion, hemodialysis membrane are high technology products, and there is interest for improving the middle molecule removal by medium cutoff membrane in hemodialysis and with high cutoff membrane in myeloma, for example. Improving the biocompatibility and the optimized component and surface functioning is very important towards a better life for dialysis patient. And the second improvement in the dialysis here was how can we use the artificial intelligence and the big data analysis to get a better life for dialysis patient. As you all know, our dialysis patient, 62% finished the session with fatigue, 44% with cramps, 42% with low blood pressure, and 40% took 4 hours to recover. So they are not living a happy life with our protocol, which is given all patients the same treatment. So we should go a little bit into individualization or giving what we call dialysis a la carte. So how to do this? It is very important to revise the data of each patient by artificial intelligence and plot all this data to tailor for each patient what is suitable for him, the type of filter, the type of time, the time factor, and how the dialysis session will be. And here I will present 6 papers coming from 6 parts of the world, one of them by Professor Cano, for example, in kidney diseases, development of artificial intelligence model to guide the management of blood pressure, fluid volume, and dialysis dose. Another one here is coming from China. A third one is coming from Japan, which is called the Silico study. All these are addressing the same aspect, which is how to tailor the dialysis according to the patient. Now, this is a man that I don't like very much, but he did something good for the nephrology when he signed this Advancing American Kidney Health Initiative, or what we call AAKH, telling that all our dialysis patients, why he signed this? Because there is poor outcome for patients on dialysis. Dialysis is not patient-centered, and there is very low rate of home dialysis in the United States, and few therapy to treat and prevent kidney disease progression. And the wait list is more than 100,000. And the kidney care is very costly, 114 billion in 2016. So when he signed this, he told that the first aim is to reduce the development of end stage by prevention program. And so in 2030, he wants to decrease by 25% the number. He makes by that time, 80% of the patients on home dialysis program. And I will tell you later on why home dialysis is beneficial, not only cost-wise, but also CO2 emission-wise, as I will tell you in the last part of my talk. So there is new value-based kidney disease payment model that align provider incentive for those who put the patient on home dialysis treatment, and for those who send the patient for transplantation. He signed that expanding the use of hepatitis C virus positive organs. Actually, this was started by his precedor, Obama, and support of living donor by expanding the reimbursement of travel and subsistence expenses. And as he is a businessman, he's giving more incentive for transplant physician who send their patient for transplantation. The sixth part is the green nephrology. And in this green nephrology, we will be speaking about the Glasgow Environment Summit attended by Newcastle University Hospital. You see that 2019, they made a study how much CO2 is coming from each dialysis patient. Per session, there is 23.4 kilograms CO2. So if we multiply this per patient per year, it is 3.7 ton. And if we have 30,000 patients on dialysis, it becomes 110,000 ton of CO2. And if we multiply this by 2, because we have around 60,000 patients on dialysis in Egypt, we have 220 ton of CO2 coming from the dialysis module. Why this CO2 is coming? It is coming from the pharmaceutical and consumable, from the energy use during dialysis, from the travel of the patient by cars and by different ways of transport, by the waste disposal, by the water of dialysis, and by the food the patient is taking during the dialysis. And when they compare this, as I told you, if the patient is doing home hemodialysis, for example, 5.5 hours, 3 hours, 5 times per week, for example, he only emits 1,800 kilograms of CO2. But if he, for example, when we compare this with our classic program, which is 3 times 4 hours in a center, it is almost more than double. It is 3,818 kilograms of CO2. Therefore, when I told you about the home hemodialysis program of the United States, they wanted to have more mobile home hemodialysis to get less CO2 and less expenses at the same time. Right. How to decrease the CO2 emission? I will give you what they are tried in the United Kingdom. They are taking the water coming, the injected water from the purification system, and are using it to hospital toilets to wash and for the sewage. They are taking a central acid station, a canister, instead of having different cartridges. They are giving the patient the minimal amount of food during the dialysis, only a new sandwich menu. They are telling the patient each one to bring his linen with him, his cover with him, and this will decrease the cost and saving. All these are different ways to decrease the CO2 emission. Now let's go to the 7th part of my talk, which is malnutrition. And this was presented by Professor Abdul Halim Abdul Ghafoor, the president of the Malaysian Society of Nephrology, telling that this is an important problem in nephrology. The prevalence is around 1/3 to 2/3 of all our dialysis patients, depending on the criteria of diagnosis. And it's more common than in non-CKD patients. With increased mortality, with reduced quality of life, with increased hospitalization, increased inflammation, and vascular calcification. Unfortunately, we don't take much concentration on this aspect of measuring the nutritional status of our patient. Of course, we have different markers like the albumin or the body fat mass, but there are some anthropometric measures which could be applied very important clinically. One of them that he suggested is called the ultrasound quadriceps, to see the quadriceps muscle thickness and cross-sectional area of the rectus femoris by ultrasound. So if it is decreased, this means that this patient is debilitated or has got frailty and needs better nutrition. Again, of course, the body mass index is a simple marker, but we have other markers like quadriceps, as I told you, in addition to the classic markers that you are using in general. It is very important to have a dietitian in our unit, which is something very deficient. And in case we have the patient with severe undernutrition, we can go to intradiabetic parenteral nutrition in some patient. And according to two studies that I will present you, after omega-3 fatty acid addition, efficacy of nutritional intervention on inflammatory marker in hemodialysis patient, a systematic review. And this is a limited analysis showing that those patients who took omega-3 were better than those who didn't took. Another study about vitamin E was not very impressive, and it was almost the same result in the two groups. Malnutrition does not only affect adults, but it comes from since childhood. And the problem is presented here from this presentation from Jamaica, telling that the estimated prevalence of small births in low and middle income country like South America and Africa and Asia is increasing. And they found, unfortunately, that 1 kilogram increase in the body weight of the baby is associated with increase of 1/4 million of glomeruli and of 2.6 to 7 milliliter per minute in the GFR. So when you have a premature baby, you expect that his glomeruli are less and his lifetime risk of chronic kidney disease will be increased in comparison to a normal birth weight baby. And so it is very important to start the treatment in utero and to avoid what will happen later on when you get a malnutritional baby, according to Brenner hypothesis of decreased nephron, which may end in the future into renal disease. And in summary, early life factor, maternal, prenatal, and infancy have a developmental origin in hypertension, diabetes, and obesity, all of which can impact the kidney. Various systems, including the kidney, may be permanently altered, leading to nephron and tubular change. Intervention, therefore, is important in the maternal, fetal, and the infancy period. Simple prevention measures, such as promoting breastfeeding and physical activity in early childhood, early nutritional education, and public nutritional policy can have significant beneficial activity and having a better life. My last part is the calcific uremic arteriolopathy, or what we call calciphylaxis. You think that this is something rare. Of course, the demographic here, more in females, more with diabetics, with those with vitamin K deficiency, high calcium, high phosphate, high PTH in the laboratory, some medication like warfarin, calcium, and vitamin D. But when in this epidemiological study coming from the United States and presented in the World Congress of Nephrology, they found that it is not as rare as you think. They found that the annual incidence is 35 cases per 10,000 in hemodialysis patients. And the median duration between hemodialysis and the development of calciphylaxis was around 3 years. And the mean ages were 54 years, more common, as I told you, in females. When compared this US data of 35,000 per 100,000 to Germany, they found in Germany it is much less, only 4 per 10,000. And in Japan, it is only 1 per 10,000. So why Europe and Japan are better than United States? Maybe because they are using less calcium or less vitamin D. We don't know exactly the cause, but these are some theories of treatment. You have to eliminate the risk factor. I mean, stop calcium-based phosphate binder, withhold vitamin D, and therefore, in the new KDIGO guidelines, you will not find vitamin D routine, as was in the previous days. Sinacalcet, intensify hemodialysis, and stop warfarin. Of course, you should manage the wound. You should give, in the florid cases, sodium thiosulfate, which work as antioxidant and vasodilatory you may give bisphosphonate and vitamin K, because in the etiology we say that vitamin K could be one of the causes, and one of the treatment line is parathyroid gland removal. And here in this study coming from Paris, French case control study shows that the mortality in 1 year is very high, 40%, and in 5 years it is 56%. So it's still a very important thing, although rare, but it is lethal. At the end, dear colleagues, I hope in this summary that I took you for around 1 hour or a little bit more, I try to give you an idea that aging could be controlled by food, maybe, and that the aging is associated with some changes in the T and D lymphocytes, which lead to tertiary lymphoid tissue and possibly progression to kidney fibrosis. That the artificial kidney dream is still under investigation with new development of organoids and possibility of having an artificial kidney, either by a sort of bioprinting or maybe by a xenotransplantation, like what Professor Montgomery did in the last few months. Glomerular diseases has got much advances in the treatment, with 5 new drugs in the treatment of IgA nephropathy, with possibly no immunosuppression in membranous nephropathy if you find a titer of anti-PLA less than 40, but definite treatment with immunosuppression if the titer is more than 275. That lupus nephritis has got at least 5 new drugs, ANCA vasculitis at least 5 new drugs. Pediatric nephrology now is benefiting from the advances in adult nephrology by doing almost similar treatment. Sickle cell disease is controllable by some drugs like hydroxyurea and even the new SGLT2 inhibitors. AKI in the world is still with high mortality, whether in high income or low income country, because mortality will not depend on the income. But the etiology maybe is different. And the roadmap for innovation in dialysis is still high, with new membranes, artificial intelligence to be applied for all our patients, and applying the American dream of having in 2030, 80% of the patient on home hemodialysis, and maybe most of the patient going to transplantation. Green nephrology is getting less CO2 emission by addressing the environment, using maybe more home hemodialysis, less food during dialysis session, recycling of the water coming from the dialysis program, and malnutrition should be controlled, of course. And there are some new markers like the ultrasound of the quadriceps. The malnutrition should be treated very early in low birth babies, because they will have less number of nephrons in the future and may be prone to CKD in the future. And vascular calcification in CKD is not very rare as we think, although the data from the United States are much more than from Germany and Japan. And of course, we need more statistics, because as I told you, in the first days, they told COVID killed only 5 million, and nowadays they are telling it is from 13 to 15 million deaths. Thank you very much for your attendance.
Thank you, Professor Hani, for this very, very, very illustrative and very rich journey through the last conferences in nephrology, in ASN, World Congress of Nephrology, EDTA, and many, many other papers, many others, even going through the new guidelines of GN, and going into something rare but complex, something in pathogenic and treatment like vascular calcification at the end, and the new hope to have a green nephrology. It is very, very rich talk, and thank you as usual, and we would like to thank you. And before we start our discussion, excuse me to thank you again for augmenting my usual feeling regarding the point of membranous nephropathy, that we are over-suppressing our patients with glomerulonephritis. We are usually giving a huge amount of immunosuppression that the patient may need at this time and needs much less doses and exposing him to many dangers. Thank you very much.
Thank you very much, Professor Yasser, and I agree with you that as you saw in this study of rituximab, that it causes secondary immunodeficiency and makes the patient taking the vaccine of COVID not able to develop proper protection. This is an example of overuse of immunosuppression, because nowadays rituximab is prescribed for any glomerulonephritis without a real reason, yes, even in mild cases. This is an example of what you are telling. Another example is that the cases of ANCA vasculitis also have a big some of cases are quiescent and other are very fulminant, needing the aggressive treatment. So not all the patients with glomerular disease are the same. And the very recent data of Membranos are highlighting this. You should have a biomarker or some parameter telling you which patient to have immunosuppression and which patient who does not need immunosuppression. And I think this anti-PLA level could be a new way of guiding the treatment of our patients.
Yes, we have now a numerical marker to depend upon for the amount of immunosuppression and how to go through immunosuppression. Professor Hisham Sayed. Professor Hisham Sayed wants to comment.
Thank you very much, Professor Dr. Hani. As usual, it is a fast journey to the moon, looking from upside down what's happening on the ground.
Yes.
So we have a global view that we can fly through the nephrology, all through your updated and excited, very approaching different aspects in nephrology. And I have thank you again for the highlighting the food. In the past of the Chinese imperials who found that the elixir of life and who unfortunately died from heavy metals, who are sharing the Chinese imperials. So it was in the past centuries, but now we can have an insight how the food itself can improve. And if you look to the UK, for example, the kings and the others who are living 95 years, I think there is a secret in their food. So I would like to thank you very much. And thank you again for the highlighting the dialysis membrane update. And in particular, we touched that issue probably 3 or 4 years, the post-dialysis fatigue. And it is a very bad thing to have a quality of life and denoting higher mortality. I remember that there was a paper that it is equal in the mortality like serum albumin exactly. So we have to took that in important issue that patients complaining of post-dialysis fatigue should be considered. And I think sodium modeling and others, and you mentioned perfectly the individualization. I like very much the term individualization a la carte of the hemodialysis patient. Finally, before asking you a question, the sodium thiosulfate for calcific uremic arteriopathy, it was tried before in the dialysate path as a canister of the dialysate containing sodium thiosulfate and was promising. But I think there is no up till now a clinical solid data on that way. May I ask you if you allowed me to ask you about the DABA?
Yes, please.
The DABA, we know that the sodium glucose cotransporter inhibitor has insight for the management of diabetic and as well on the chronic kidney disease on the aspect of the maximum tolerated dose of ARES or ARBs. So do you think that sodium glucose cotransporters could be one of the management, even if the patient is not taking ACE or ARBs in the future, or it should be linked? And how is its role in the nephropathy, glomerulopathy, that it is less in diabetic, but has some insight in proteinuria and progression to kidney. For sure, in diabetes is much higher. So any update on this field, on the regulation guidelines, putting very early sodium glucose co-transporter?
Actually, of course, thank you very much for your comments, Professor Hisham. And I appreciate very much your support for the new models of dialysis. Until nowadays, we see the high flux, for example, present in many of our dialysis units, which was not the state
pushing for years.
A few years ago, it was not like this. So now it is you are pushing, and many people are listening to what you are saying. Regarding the SGLT2 inhibitor, I think it's a little bit premature to put them instead of ACE or ARBs because of the time factor. You know, the data about ACE and ARBs come back maybe more than 20 years nowadays.
Exactly.
And we have so many studies, starting from the very old studies of decrease in proteinuria up till the recent study, even combining, for example, the ARB with endothelin receptor blocker, like in the Duet study addressing the new drugs used in FSGS or in IgA nephropathy. But all these need the factor of time to see the side effect. What I'm afraid of is that there is a plethora of enthusiasm with SGLT2 inhibitor in the last few months, or in the last maybe 1 or 2 years, that I want to see it with more how we call meta-analysis, comparing those who take these drugs versus those who did not take or add on ACE and ARB. We don't have much data about that. And what makes me a little bit cautious, some reports that were present, as you remember, a few years ago, about the toxicities of these drugs regarding, for example, the increased incidence of amputation with some of them, increased incidence of gangrene and scrotal problems with some of them, increased the incidence of UTI with some of them, and suddenly you found all this data abolished or vanished from the literature. You don't see any data about that, about any side effect. All the data now are very pink and very nice.
Yes, exactly.
So I would say let's wait time and see after, because you remember when the statins, for example, started to appear, they were telling that this statin will treat everything. It is the poly pill which will help, and how we call it, pleiotropic effect of statin. And nowadays it's
antioxidant and hyperlipidemic and
after that it came to its real situation as mainly a lipid lowering drug with some benefit possible, but mainly it's a lipid lowering drug. So I think the plethora of data about SGLT2 in every indication will increase and will come to a plateau after some time. And at that time, you can say that it could be added to ACE or ARB, but I think ACE and ARB have got a more solid state in nephrology till now.
What make me in doubt, one study published recently, a few months ago, that although we know that sodium glucose co-transporter has another drop in the GFR at the first start of treatment, however, they studied that as a prophylaxis against acute kidney injury in some patients, and they found that they are less in acute kidney injury in many patients coming in the hospital. So I understand that the plethora of papers, and I fully agree that we have to wait more solid and long scale as well on long term. Thank you very much, Professor Dr. Hani.
This exactly was my question to Professor Tarek Elbaz in his session last Ramadan about proteinuria, that I asked him if you do expect that SGLT2 inhibitors will be the kidney-specific drugs in the near future. All professors answered me it is too early for this to consider it as this drug. In spite of that, the studies are directing against them in diabetic nephropathy and many GN, IgA, or FSGS, and etc. But now it is still, I think, as you mentioned, it is early to consider them one of the kidney-specific drugs. Thank you for highlighting also the point of rituximab as being in maintenance in vasculitis, as it was started to be used in induction therapy. And by this way, Dr. Rami Shahat asked a question about your experience, Professor Hani, in using rituximab in maintenance GN, treatment of glomerulonephritis. For how long, and how long do you recommend to continue the treatment with this drug as a maintenance?
Thank you for the question. Of course, I think what I presented is its use as a maintenance in ANCA vasculitis, which is a resistant type of GN, but not in all, because many glomerulonephritis could be controlled in maintenance with much less aggressive treatment. Yeah, but ANCA being aggressive, so we start, for example, by cyclophosphamide, which works fast, and as I told you, it is very important to reach a control in the first 3 months of the disease, not to have a higher mortality later on. And after that, you can give rituximab in a protocol of monthly basis, I think, for the maintenance. It could be more spaced every 6 weeks, for example, if the condition abates, because in comparison to MMF, the results are better in case of ANCA vasculitis. But in other types of GN, I would reserve rituximab to the aggressive flare. I will not use it as a maintenance. I would go, for example, in Membranos by ACE and ARB, as I told you, if the titer is low or if the condition is quiescent, or maybe we will control by small dose of calcineurin inhibitor, whether tacrolimus or cyclosporin, as well as in focal sclerosis, as well as in minimal. And I don't think there will be a very big role for rituximab in the maintenance, but it could be used, of course, in the flares or in the steroid sparing regimen. Definitely, it will help us to use less steroid. And of course, it will still have a role in all aggressive condition needing sometimes in lupus, for example, but although the Gazyva would be more efficient, but still rituximab also could be used. So still rituximab could be used in many indications, but its use in maintenance, I think, is more in ANCA vasculitis rather than other types of GN.
Okay, Professor Saeed Khamis is with us. Welcome, Professor Saeed.
Thank you, Professor Yasser. Thank you, Professor Hani, for this elegant presentation as usual.
Thank you very much, Dr. Saeed.
Just I have 3 short questions. Number one, regarding the, thank you. Number one, the sodium thiosulfate. From your own your experience regarding the use of sodium thiosulfate in calciphylaxis, that's number one. Number two, this the use of probiotics. I think we are, as the nephrologists, are reluctant to use these probiotics, despite it incriminated in many pathogenistic pathways in our renal disorders. Number three, regarding the dialysis or fatigue, post-dialysis fatigue, as Professor Hisham said, that the dialysis recovery time, it is a marker of dialysis adequacy. Do you think if we use hemodiafiltration in comparison with the conventional dialysis, can we lessen the incidence of this problematic or big problem for our patients, this post-dialysis fatigue? And thank you so much.
Thank you very much, Professor Saeed, for these important questions. Regarding the first question, actually, my personal experience is not very much. I used it in 2 patients in a private hospital, big private hospital in Cairo. And this sodium thiosulfate gave very good result in management of this vascular calcification or calciphylaxis. It was very efficient in the control of these 2 cases. Regarding the second use of probiotics, of course, as I mentioned in the food part of my talk, it is very important to combat the harmful bacteria by enhancing or increasing the beneficial bacteria. And one of the way of this, of course, is to use الحاجات الطبيعية اللي احنا بنستخدمها زي الردة والزبادي والحاجات اللي هي تحتوي على البروبيوتيك أو الانزيمز الهيلبفول بكتيريا to increase them in the gut and combat especially in Egypt, in which there is an overuse of antibiotics for anything without prescription. Regarding the third question regarding the post-dialysis fatigue, I agree with you that the newer model of dialysis, including hemodiafiltration, are usually associated with less incidence of post-dialysis fatigue. Although, of course, this post-dialysis fatigue should be analyzed to see if there is, for example, hypotension, if there is hypokalemia. I mean, to know what is the exact cause of malnutrition, for example, or what is the cause exactly of the post-dialysis fatigue. In a way, maybe we are a little bit away from using artificial intelligence, but at least we could analyze the data of the patient from the previous records and from the previous dialysis session and try to know why he is getting fatigue and try different dialysis modalities or dialysis, for example, surface areas of the filter and see which type does not cause the fatigue in this specific patient.
Okay, thank you, Professor Hani. From Dr. Khalid Abu Zaid, he is asking about a patient, a case scenario, low titer titer less than 40 with massive proteinuria, more than 4 grams per day. Would have the same chance of a spontaneous recovery? If yes, for how long would you wait till spontaneous recovery?
Thank you for the question, Dr. Khalid. According to this recent study from Paris, they يعني قالوا ان ال 40 is a cutoff, you know, if it is less than 40, but I don't think in their cases they got that high degree of proteinuria. يعني ما كانش up to 4 grams. I think انه if it is 4 grams, it's a little bit يعني against الكرايتيريا اللي هم اختاروا فيها البيشنتس بتوعهم، كانوا يعني rather quiescent patient، ما كانش عندهم very يعني aggressive proteinuria كده. For such patient I would start الحقيقة to add immunosuppression after a short period of ACE and يعني الأول نجرب الحاجات الكلاسيك اللي هي without immunosuppression، لكن أبتدي أزود حاجة من الكالسينيورين inhibitors according to literature اللي هي إن ممكن الكالسينيورين inhibitor تبقى beneficial بالنسبة للممبرانس في الأيرلي يوز.
Okay. Another question that Dr. Hisham Said may also help us in its answer about the use of kidmin for dialysis patients and how to overcome the problem of giving it in the venous lymph, and recommendations for this drug in dialysis patients, if there is a specific recommendation regarding this drug.
For sure, nutrition support is required in most of that, especially with the leaky membrane. We know that leaky membrane can have an amino acid dialyzable. So I would give protein-enriched diet, whatever it is oral or it is.
Can you repeat, please, in clear words to Dr. Hisham?
With the modern dialysis membrane, we have leaky membrane at least for amino acid and 10 grams of albumin even. In our last studies, there is around 2 grams loss in hemodiafiltration using more permeable dialysis membrane. So the question is required for nutritional support. The answer is yes. Whatever it is IV or oral, I prefer the oral intake of high protein diet because it supplies more amino acids than in IV solutions. So if the patient is good, steak, healthy, can eat, has a good appetite, no signs of inflammation and whatever, so we can start by oral intake, and there is a lot of enriched protein solution by oral by different companies. So I think IV is not suitable for such patients.
You recommend oral intake?
Yes.
I agree with Dr. Hisham ان احنا we should encourage the patient to eat well first and we may give oral supplementation لانه البروبلم اوف malnutrition according للستادي اللي انا عرضتها بتاعت ماليزيا it's a common problem يعني from 1/3 to 2/3 of all our patients يعني it's not uncommon واحنا الحقيقه بنتغافل عن هذا الموضوع بنعتبر اننا ممكن خلاص العين بيعمل good dialysis and no need for nutrition although ان هو الفريليتي is directly proportional to the mortality. So if we keep the patient on dialysis while they are weak, they will ultimately die early.
Yes, there is my recent research as well in the alpha-1 microglobulin is coming from the liver and one of the uremic toxin. It is 24 or 25,000 Dalton and it's related to sterility and inflammation. As you perfectly described, that nutrition is usually missed in the education of the patient in incident dialysis patients, especially who have experiences in chronic kidney disease and low protein diet, and they may extend months on the same regimen. So I think one of the goals is to educate patients to eat well once they started the dialysis therapy.
Thank you. Dr. Rasha Darwish wants to comment.
First of all, I would like to thank you, Dr. Hani, for this amazing lecture. I mean, you did manage to summarize lots of very important conferences in 1 hour. So thank you so much for the effort. And my question is related to this issue about malnutrition. Why in particular did they suggest that measuring the quadriceps measurements by ultrasound is more beneficial than other ways we are used to regarding assessment of malnutrition? Why is it suggested in particular? Why is it so more different? That's my question.
Thank you very much, Dr. Rasha. هو البوينت إن هو they suggested some simple ways to monitor. لكن of course the classic parameters العادية اللي احنا بنشوف يعني ممكن نشوف السكين فولدز نشوف الترايسبس diameter ممكن الحاجات اللي هي الكلاسيك بارامترز بتاعتنا سهلة لكن هو كان الاستادي ان ممكن يبقى فيه more accurate parameter for mainly research study for comparative purposes ان هو يقدر يقيس مثلا الكوادريسبس ده بالالتراساوند او بالاضافه للبارامترز العاديه بتاعت النيوتريشن يعني ما كانش ليها افضليه هي كانت حاجه زياده هو حطها من ضمن الايه التولز اللي ممكن تستخدم to assess the nutritional status.
But it is not suggested as an alternative أو حاجة.
لا, it's not. لا, it's add on. يعني it's another. يعني if the other ways give يعني give us an idea about the malnutrition status of the patient, of course it will help. يمكن هي it's a parameter طبعا of الفيزيكال فيتنس. أنا عارف إن حضرتك مهتمة كمان بالفيزيكال فيتنس. ف it gives us an idea about the musculature of the patient. لأنه طبعا لو quadriceps diameter كويس معناه إنه هو he's fit running well أو بيعمل رياضة بصورة منتظمة شوية.
Okay,
thank you.
Thank you. I have another question, Dr. Hani, if you don't mind, just another question regarding artificial intelligence. I'm wondering if they were talking about the availability of more affordable gadgets regarding artificial intelligence, like home dialysis, like following up patients for doctors in their centers.
Thank you for raising this point. هو دلوقتي يمكن في باريس في المؤتمر بتاع الإيديتا الأخراني كانوا مركزين في الستاديز بتاعت الارتفيشال انتليجنس على اليوز اوف موبايل فونز. ان ممكن قوي الداتا بتاعت البيشنت سواء كانت انه عايزين نتابعه وهو بيعمل هوم هيمودياليسيس او كل الداتا دي تنقل عن طريق الموبايلز لان كل الناس دلوقتي تقريبا عندها موبايلز. فان بيبقى في بروجرام على الموبايل فون عند البيشنت نفسه كوميونيكيتنج مع الدياليسيس يونت وكوميونيكيتنج مع التريتنج نيرس او تريتنج فيزيشن وبالتالي ممكن يتيلر ويبقى في انتر اكشن minute by minute through mobile phone. واعتقد ان هو ده هيبقى الحاجه الفيري applicable with the future ان احنا هنستخدم الموبايلات في علاج المرضى او في متابعه مرضى الدياليسيس.
Thank you so much, Dr. Hani. Thank you so much.
Professor Shams Sayed, again.
Thank you very much for highlighting the artificial intelligence. It was emergent in early 2019, how to apply in clinical practice the artificial intelligence on dialysis. And one of them is the online dialysis machine sending all the parameters for each patient in each session to collect the data on hemodialysis session. So there is no prescription or paperwork, there is online, they started that. And even they apply the artificial intelligence in anemia management in patients on dialysis and on PKD to adjust the dose. The whole of artificial intelligence in the field of nephrology is growing up. And I think it should be like that, because all the researches in the dialysis is low number and shorter duration. So I think it's one of the goals is to improve dialysis with artificial intelligence. And thank you very much for highlighting this.
Even in AKI, it's going strongly in predicting AKI.
Yes.
Also the electronic files and making an electronic alert. And
there is nowadays trying what is the sensor on the wrist for each patient that is electronically connected, and they can even diagnose hyperkalemia from the past changes, and they can send a message early to the patient to go direct to the dialysis unit because there is risk. So there is an advance in technology.
Yes. Thank you for highlighting this point and for your answers. The last point to be discussed in this very rich and very fruitful discussion is about the treatment of lupus. We have two questions. One from me. Dr. Hani, you mentioned 5 recent lines for treatment of lupus. Is there a specification for a specific class for each drug, such as, for example, you mentioned the triple therapy that is used for membranous lupus, other than drugs specific for special class form of lupus, or still not yet determined?
Thank you, Professor Yasser. Most of these drugs has been used in type 3 to 4.
Type 3
and 4. 3 and 4. يعني اكتر في 4 على اساس ان 4 بيبقى اجريسيف اكتر طبعا بالنسبه للكدني فانكشن. They don't use قوي الترايلز دي في الادفانسد تايبس، لانه بيبقى اوريدي الفايبروسيس ما بيسمحش للانفلاماتوري ماركرز ان هي تبقى المين فاكتور، وبالتالي بتبقى يوزلس انك تجيف سترونج دراجز تكون بتشتغل على الاميون سيستم. لكن تايب 3 و 4 هم اللي بيبقوا التارجت في معظم الحالات. وبالنسبه للايرلي تايبس اللي هي 1 or 2 برضو يعني most of the studies ما بتعملش inclusion لهؤلاء البيشنتس، لانه بيبقى مش يعني ممكن يتحسن بالسيمبل مانجمنت بتاعت اللوبس اللي هي ستيرويدز وممكن هيدروكسيكلوروكوين، الحاجات البسيطه اللي بيستخدموها الروماتولوجيست.
Yes, and this comes to the second question, leads us to the second question that new drugs in the resistant cases of cyclophosphamide or MMF class 4, or do you recommend from the start of treatment or only in resistant cases by Dr. Rami Shahat?
Thank you دكتور رامي. هو according للكي ديجو 2021 اللي انا حطيتها برضو محطوطه كانت اتعرضت في الورد كونجرس اوف نيفرولوجي، هم حاطين ان النيو دراجز to be used alternative if failed، يعني تبقى هي بديل مش من الاول. يعني مش هيدي فوكلوسبورين مثلا او يدي بلوموماب قبل ما يجرب ان هو يدي الحاجات الكلاسيكيه الاول. يعني مش محطوطه في الجايد لاين نمره 1، محطوطه after failure يعني.
Professor Hani, here we have no more questions and no more comments except the last comment by Professor Saeed Khamis to stress on that about the very rich, thank you for this very rich session highlighting all the important topics of the last conferences. He's stressing to thank you again in the last session.
Thank you very much. It was my pleasure.
It was magnificent.
Yes, really was one of the most magnificent sessions in this.
Thank you very much for this compliment. والحقيقة ما استحقش هذا الكومبلمنت يعني.
دكتور هاني حضرتك as usual يعني الحقيقه السيشن بتاعت حضرتك بتبقى مميزه جدا. Thank you.
Thank you
and
very,
very important lectures. And excuse me to close this very hot session and thank Professor Hani for his very illustrative effort in illustrating all of these recent topics and making us, as we were all attending these all conferences. And thank you all professors who shared the discussion, Professor Sham Sayed, Professor Sham Khamis, Dr. Rasha Darwish, and thank you for all attendees who were with us and lasted till late night and shared by their questions to enrich this session. Thank you again, Professor Hani.
Thank you very much. And
thank you.
Thank you very much. Thank you.
And excuse me to close and announce as usual about the coming session next Wednesday, 9 p.m. inshallah in our usual time. Dr. Zaghlul Safi will speak about difficult IV insertions and difficult cases of vascular access, in end-stage renal disease patient on dialysis.
Interesting, inshallah.
Thank you very much. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
شكرا.